Okay, thank you so much, Jimmy, the background. Good afternoon, ladies and gentlemen, colleagues, the healthcare community practices. Welcome to the 80th session of the ECHO, where today we shall be concentrating on infection prevention and control training for healthcare workers. This training is supported by SEED Global Health, which envisions a world whereby the health workforce is robust and strengthened, and they concentrate on community health, emergency care, maternal, neonatal, and child health. We are very much grateful for being here with you, and you're all welcome aboard. As earlier alluded, today's session, we are going to focus on infection prevention and control, and we all know what is happening in the country. Ebola outbreak from the time it was announced. And therefore, that means that we need to create more awareness, share the knowledge, and be prepared, as we all know how it has always turned out. So I am Dr. Edwin Ouma. I am going to be the moderator for this session. And I'm going to be joined by a panel of experts who are going to lead us in this knowledge sharing session. They will introduce themselves. One will be online, another is here physical with me. So that's great. I think, is he on? Okay. Wait for him to get introduced. I will request the expert in the room. They are two ladies to introduce themselves and anything about them that they wish the public to know before we go into our session proper. Over to you.
Yes, well, thank you so much. A very good afternoon to everyone, our colleagues in this, in the medical fraternity. I am Dr. Ssuda Namubiru Chizito. I'm a clinical microbiologist and an IPC specialist, but I'm also an epidemiologist with interest in infectious diseases and control of antimicrobial resistance. I'm happy to share with you today. Thank you.
Thank you.
Good afternoon, team. My name is I'm an assistant psychiatric nurse. I work in Mulago National Referral Hospital, IPC trainer. I'm blessed to be here with you. Thank you.
Thank you so much, Ssuda. As I think people need to see her. Yes, there she is. Dr. Ssuda, as she has explained and introduced herself, with Sister Komhendo Judith, are with us here in the room. And another colleague will be joining online at the right moment, will introduce himself. But that being said, as is the culture in ECHO, today we shall not have a pretest, but we are going to inquire from members, colleagues, what their expectations are in this session. Please use the chat, go into the chat and just type what expectations you have for these 2 hours we are going to spend together. Just share with us what you hope to get out of this by the end of the session, what you expect to have learned, to have gotten out, or what you hope will be shared. As we all know, this session, we shall be talking about principles of IPC, and I'm waiting for in the chat to see what people's expectations are. We shall talk about the WHO core components of infection prevention and control. We shall have knowledge about the standard precautions in IPC practice, and then transmission-based IPC precautions. Shall have the hierarchy of controls in trying to implement IPC, and risk assessment. And then lastly, we shall end with a demonstration that will be led by Sister Komhendo Judith about donning, doffing, especially if you are in an area where you are the person expected to manage people, for example, with Ebola and such related infections. So that is what we are going to cover today. So I'm seeing in the chat people's expectations. You just help me display them so that I can read them in these 5 minutes before we can start officially. Kevin there, Ojambo, expecting to learn about IPC for Ebola and Mpox. Okay, thank you so much, Kevin. Can I have a viewpoint of the chat? The coordinator there so that I can be able to read people's expectations. Keep them coming in. We shall not have a test as usual, but we shall have these expectations, and at the end of the session, we hope to see that we've achieved all of them that people need. So Kevin was saying, hopes to learn about Ebola and Mpox questions there. We have Achola Jackie who wants to know about IPC. Okay. James Ebugu expects to receive more on IPC and perhaps be prepared to face head-on with the epidemic. Are you in the areas that the epidemic is already ravaging? If that is the situation, today you are in luck because you will get to know that. Issa would like to know about waste management or waste segregation in hospital setup and supply on IPC, okay? And then David carrying out an IPC audit. Okay. Kevin, David, James, Issa, those have been well noted. Colleagues, keep pouring in your expectations because they will help us understand or know if we have achieved all that we'd love to learn today. I don't know if Allan is now on board because we're about to start this session. Would introduce himself once and for all, and then we'll be able to kickstart this off. Once again, is he on? Not yet. This is the 80th ECHO session, and we are having infection prevention and control. After 2 weeks, we shall be tackling another topic, which will be acute poisoning. We shall be having approach to acutely poisoned patient. So without any further ado, with that being said, about this time, we shall have the first expert, that is Dr. Ssuda, taking on the first 15 minutes to discuss with us the principles of IPC, the WHO core components of IPC, the standard IPC precautions. And then after that, our next expert, who will introduce himself at that time, will take us through the remaining subtopics. With that, very much welcome, Dr. Ssuda. The floor is yours. Thank you.
Thank you so much, moderator. I will now share my screen.
Great.
So like the moderator has said, infection prevention and control for healthcare workers, both those who are supporting routine healthcare services, but also those ones who are responding to Ebola outbreaks or any outbreak, because we have a couple of outbreaks currently in the country, and this is meant for generally infection prevention and control for all those situations. So we shall have an introduction to infection prevention and control, the core components, how infections are spread, the standard precautions that we should always follow, the transmission-based precautions, the hierarchy of controls, and a risk assessment. So infection prevention and control, sometimes commonly denoted as IPC, is a scientific phenomena or a scientific approach which has practical solutions designed to prevent harm caused by infections. It is grounded in principles of infectious diseases, epidemiology, the social sciences, because it has an aspect of behavior change communication and health system strengthening, and is rooted in patient safety and health service quality. So you have all the aspects that are rooted, but at the end of the day, we are looking at patient safety, but also health service quality. And the purpose of infection prevention and control. Now, infection prevention and control is a very selfish phenomena and it really resonates with humanity, that we start with ourselves, so we protect ourselves, then we protect the patients that we serve, and most importantly, we protect the family and the communities. The target audience for this is all healthcare workers, health facility managers, clinicians, and IPC practitioners across the various healthcare settings. It does not matter whether it's a primary care clinic, it could be an emergency department, it could be an infectious disease clinic, or even more. So everyone who is a healthcare worker, and these healthcare workers also include, of course, the community extension workers, or our VHTs, because they also play a very big role, as we shall continue to see. Infection prevention and control has core components, and it is a stepwise approach towards the implementation of infection prevention and control at the national and facility level to provide minimum protection and safety to patients, the healthcare workers, the visitors, based on the WHO core components of an infection prevention and control program. Now, the infection prevention and control program is basically that system that is ensuring that we have practice or effective practice of infection prevention and control. And it has a lot of interrelated programs that come together. We have the guidelines, and currently Ministry of Health has a national IPC framework and guideline for infection prevention and control. Then we have education and training, because it is useless to have guidelines without people actually being educated or trained. And that is why we want to thank partners like SEED Global, the Emergency Department of Ministry of Health, and the larger healthcare worker fraternity that have come together to ensure that we get the education and training. Then we have the surveillance, because for us to be able to prevent or control infections, then we have to ensure that we have the surveillance to know which infections are actually circulating, so that when we know what is circulating, then we can prevent it. And then, of course, very importantly, monitoring, audit. Now you monitor what you're doing, you audit what you're doing, and also feedback. But all this is not possible if you don't have an enabling environment. And this enabling environment, as we shall see, has other areas that are very key to it. But we have areas like the workload, because you cannot practice infection prevention and control when you're overwhelmed with so many patients, you do not have the staff, the bed occupancy is beyond what is recommended, the built environment is lacking, you do not have the materials and the equipment. So all those ones give us what we call the multimodal strategy for infection prevention and control, and all those ones constitute the core components. And as you can realize, everyone has a role to play, even if you're a facility manager or you're the actual health worker who is seeing a patient, you all have a role to play. And of course, even the patients, because when you're doing education and training, it is for healthcare workers and the patients. But what are the goals? If we have infection prevention and control, what do we aim to do? Simple as it sounds, we aim to reduce transmission of healthcare associated infections. Now, this is in a healthcare facility. We don't want somebody to come in, they came in to give birth, and then they live with sepsis. the fact that they did not come in with the sepsis, when they live with the sepsis, then they have gotten a healthcare associated infection. Then to enhance the safety of the staff, the patients, and the visitors. Of course, when you get infected while in care or while providing a service, then your safety is not being taken care of. Then to enhance the ability of the organization or the health facility to respond to an. Now, there is a saying that man will perish because of the lack of knowledge, but also in infection prevention and control, we have realized that when I ask all of you, for example, how many of you comfortably move, for example, Mulago or Mbale to respond to a outbreak, the people who have the information will move easily and respond. Those who have the information will say, I don't want to die in line. So the moment you do not have the information, you do not have the confidence, and you cannot be able to respond. Then to lower or reduce the risk of the hospital or healthcare facility itself, amplifying the outbreak. Sometimes you see that one health facility now becomes a breeding ground for infection because everyone who enters there lives with an infection. So we don't want to have a breeding ground for infections, hence amplifying the outbreak. So how are infections spread? This, of course, is something that probably anyone knows, but we shall still go through it to see if what you know resonates with what is out documented. So we have what we call a chain of infections or transmission chain of infections. That if you have a test tube or you have a vial of an organism called Ebola, it cannot cause infection if it is in isolation. For example, you get your vial of Ebola and you leave it in this room and you close and go away. It will not cause infection. So in order for infection to spread, all links must be connected. And if you break one of these links, then you can stop the spread of the disease. So we have the red, of course, it is the pathogen. No wonder it is red. But this pathogen must be in a reservoir. So this reservoir could be an animal, it could be the surface, it could be in a vector. But this reservoir with its pathogen also has to have a way of how this pathogen is leaving the reservoir, that is the exit point. And then, of course, when it is leaving, for example, if it is HIV and it is leaving through maybe the secretions or the seminal fluid, then it goes through a transmission pattern and have things like sexually transmitted, mother to child. But even when, for example, you're having a man who has HIV and maybe now he's the reservoir, and then you're having an exit point where his semen is leaving him with the virus. If it does not have a transmission pattern, that means you're not having sexual intercourse with another person, and there should be an entry point. For example, if they have sexual intercourse, but it is protected and they're having a condom, then there will be no entry point. But then most importantly also is you must have a susceptible host. So a susceptible host depends on which disease it is. Of course, many of the diseases, many of us are susceptible, but some people are even more susceptible. But for diseases where you need, for example, receptors, you might find that there are people who do not get HIV, even when the rest of the chain has been interlinked. But if you don't have a susceptible host, somebody does not have the receptors, then they will not get infected. So after looking at that chain of transmission of infections, then we want to know how is this chain, how can you break this chain? And how you break this chain is first of all understanding, like I said, the infectious agents grow and reproduce. And the port of exit could be blood, secretions, and excretions. And these are different avenues in which the pathogen transmission now and which sample, for example, if you're doing a lab test, which samples do you take because of the so it could be physical contact, it could be droplets, it could be airborne, fecal oral. So the motivation will put. We do not want to put in place fecal oral precautions when you're having a sexually transmitted disease. You will definitely not achieve those of entry. These are enters the mucous membrane. It could be the respiratory system, the digestive system, broken skin, etc. And then, of course, we have the susceptible host. These are individuals, and they may have traits or animals that have traits that affect their susceptibility. The immune compromise will cause disease. Who have there are people who will be exposed to TB, but they still do not develop active disease. So the immune status, things like diabetes, burn, surgery, age, will all cause this. So then after knowing this, who is at risk of infection? Remember we said there's a susceptible host, but when we look at an instance of we have several people. As you can see, we have somebody who is sweeping, we have a nurse, we have a doctor, we have several patients. But as you can see, a cleaner can give infections to a family of people who have come into the hospital. A nurse can give another patient, a doctor can give the family of visitors, and the chain continues. So
Which one?
Apologies, colleagues. I don't know at what point you lost me. Okay, but the good thing is it is still the same diagram. So what I'm saying is we have a pathogen, we have a reservoir, we have an exit point, a transmission route, entry point, and a susceptible host. So what we can do to ensure that we break this chain of transmission is to break it at the different points. We can have the pathogen, and then we can eliminate the pathogen if we can. Then we can have the reservoir. Sometimes the reservoirs are vectors. Then you can deal with the vectors, and then you have broken the chain. Then it could be at the exit point. So you're making sure that the secretions from whoever is infected do not get in touch with you, so that then you have the proper waste management and all that. Then we can have the routes of transmission, if it is airborne, if it is fecal oral, so you have all those routes. So you wash your hands and do all those. Then we have the entry point, where you have common things like maybe a mask to make sure that you don't get airborne. And then we have the susceptible host. Now, in routine services or routine care, we summarize these as standard precautions. And the standard precautions are those basic level infection control precautions, which are able to reduce the risk of transmission of pathogens from both recognized and unrecognized sources in healthcare facilities. They're supposed to be used all the time and for all patients. Doesn't matter whether it is a colleague or it is the honorable minister, they are standard precautions. So the standard precautions, the diagram on my right is showing standard precautions in the center, and then the transmission-based precautions that are outside. It means you start with these, and these include hand hygiene, simple as it is. It has been proven to reduce to over 80% of infections. Then we have respiratory hygiene and cough etiquette. Then we have appropriate isolation, which could be single room or adequate spacing between beds, depending on what organism you're suspecting. Appropriate ventilation, separate toilets, especially for patients who are highly infectious and those ones who are not infectious. Then signage precautions, where you have signages reminding people of things like, wash your hands, make sure you do not, even if it is something as simple as reduce the visiting hours, or do not, visit patients who are in the neonatal unit. So those are all precautions. Then use of appropriate PPE. Now the word appropriate is there for a reason, because you don't want to use PPE that is personal protective equipment that is not appropriate for that task and for the situation. Then of course, environmental cleaning, and this environmental cleaning is a core for both the healthcare worker and the environmentalist or the hygienist. Then we have safe injection, sharps management and injury prevention. Then patient placement, waste management, which is appropriate. Then we have safe handling and cleaning of soiled linen. This includes our uniforms, it includes the gowns. Then we have aseptic technique, and then we have proper handling of patient care equipment, including the reusable ones like the blood pressure machines and the stethoscopes. Then the transmission-based precautions, we'll just go through a few of them, and then my colleague will take it from there. These are precautions that are implemented in addition to the standard precautions when a patient is suspected or confirmed to have a certain infection or to be colonized with certain infectious microorganisms to prevent spread. And implementation one depends on the setting, the organism at hand, and the procedure being undertaken. If it is Ebola, that precautions are contact precautions, whereas if it is maybe measles, then there will be respiratory or droplet. Then the procedure being undertaken, if you're going to maybe put a cannula or intubate, then you need probably more stringent precautions as opposed to somebody who is just screening. So 3 categories of transmission-based precautions are made based on the transmission paths, and these include the contact precautions, the droplet, and the airborne. But some infections may fall in more than one category. For example, you might find that getting in contact with secretions of somebody who has, let's say, COVID-19 will get you problems, but also the droplets can also get you infected. So when do we apply the contact precautions? The contact precautions are applied when the organisms is spread by direct or indirect human contact, e.g., when you have Ebola, Lassa, or those viral hemorrhagic fevers, and they may or may not need isolation in a single room according to the local policy. Remember I said when you're applying transmission-based precautions, it depends on the context. So if you're in a context where you can afford the single room, that is the best. But where we can't, we can have a room, and then we say this is the Ebola treatment unit. Then the personal protective equipment should be used appropriately. And of course, strict hand hygiene is very essential. Then contact precautions also include enteric precautions for pathogens spread by ingestion, for which precautions such as separate toilet is necessary because you're getting in contact with a toilet and you do not want to have the same for everyone infected or not infected. And everyone, for example, in standard precautions, the signage would read, clean hands when entering and leaving the room, and clean gown and glove at the door. And then, of course, you are having doctors and staff must use patient-dedicated or disposable equipment. This is very important. Things like stethoscopes, the blood pressure machines, if you have monitors, they should be dedicated to that room or they should be disposable. And then, of course, clean and disinfect this equipment. Then the droplet infections, precautions include precautions for organisms spread by respiratory droplet. These are small quantities of liquid from the lungs, mouth, or nose that are released into air when people cough, sneeze, or speak. And examples of such diseases include influenza, meningitis, SARS-CoV. So a single room is necessary. Now here, it is even more stringent that you have a single room because you're having droplets, and droplets move a bigger distance than probably just the blood spreading from one patient to another. And of course, you need a single room to minimize, but patients may also be asked to wear a mask, and the staff may be required to wear a mask for certain healthcare procedures. So again, here the signage would be clean hands when entering and leaving the room, and then wear a mask. Then if in contact with secretions is likely, then use gowns, gloves, and eye cover. So that is the other droplet precautions. I'll hand over to the moderator to invite my colleague to take it from there. Thank you so much.
Good, good. Wherever you are, you can give a small hand clap in appreciation of the lady with a lot of data, IPC. Thank you so much, Dr. Ssuda. Now, she has taken us through the first bit of what we needed to know about what is IPC. You've seen the WHO core components of IPC. You've seen the standard IPC precautions, and you've seen that, we call it kind of a diagram that shows you the standards where we begin from, and then as we go out towards the transmission precautions, which she has ended with. And that's very important. And part of that, she has alluded to the importance of hand hygiene. As small a thing to do as hand hygiene that many people do just by going to the toilet and come back, it's still very important in the healthcare spaces. And that alone can abate as many infections as you can imagine. 80% effective. Right now, I'd like to introduce or allow Dr. Allan to introduce himself. And after that, Dr. Elizabeth Katweigye, who is the IPC pillar coordinator at MOH, who is going to help coordinate the chat in case there are any questions. Colleagues, sorry about the earlier debacle of the sound. Apologies for that. But in case you have any arising questions, in case you have something that is not clear, just type it in the chat. Dr. Elizabeth will be there to, have that handled. So, Dr. Allan, kindly unmute and introduce yourself. and then immediately start from there. You will have 15 minutes for your presentation. Thank you. Yeah, Allan, you can unmute. You are a co-host, so it should be easy for you to unmute.
Yes. Good afternoon, moderator.
Good afternoon.
You have already introduced me. I'm Dr. Allan Besiime. After these slides, the next session is supposed to be a practical demonstration of some of the IPC activities. Would like to demonstrate hand washing and also demonstrate doffing and donning of PPE. And if time allows, we shall also discuss the changes, specific precaution, specific changes in the updated guidelines for transmission-based precautions for Ebola. And they are all in the same line. Okay. So I'll need to hand over to who is going to the person who is going to present the practical demonstration.
Allan, is it okay if you first finish this presentation before we go into the practical session, which is going to happen live here?
But as
yes. Okay, then that's fine. Okay, Allan, that is well noted. Let's have Dr. Ssuda then complete the presentation, and then you will be present to work with Judith to do the demonstration. Ssuda, yes. Over back to you.
Okay, thank you so much, Dr. Allan and moderator for this. Yes, I'll start right from the airborne precautions. Remember, I told you that transmission-based precautions are 3. We have contact, we have the droplet, and now we are doing the airborne. So the airborne precautions are, again, pathogens that are spread through the small droplet nuclei. And these ones, unlike the ones before, they spread a long distance and remain in air for a long time. So the example here include measles, tuberculosis, and here we might need negative pressure or respirators depending on what we have. The signage is as above. Now, on top of the standard precautions and transmission-based precautions, we have additional control measures, which are very key. We have measures that help with elimination, physically removing the hazard. For example, if they tell you there is a vial of Ebola, then you take it away, or if you're having maybe stool of somebody who has cholera, you eliminate it. Then substitution, you can replace the hazard. Engineering controls, this is where you isolate people or you make sure the flow of patients is in such a way that it controls infections. Then administrative controls, you change the way people work. You can have people work online. You can have people work in shifts, reduce the congestion. And of course, having personal protective equipment. Now, the most effective is the elimination, and the hierarchy goes downwards. So the PPE is the least effective and the elimination is the most, but sometimes it may not be feasible. Some of the elimination controls include removing the hazard, and some of the easiest ways is to do waste segregation. For example, if you're told this patient actually had Ebola, what do? You go to the laboratory and see all the samples that were taken from this patient, and you dispose them off appropriately, then you've eliminated. Hand hygiene, because you want to ensure that you're removing the hazard from your hands. And here, I will just make mention of the 5 moments of hand hygiene that are very easy but often forgotten. We shall do the practical demonstration of hand hygiene, but just for reminding, We do hand hygiene in a healthcare facility before we touch a patient, before a clean or aseptic procedure, after body fluid contact or exposure, after touching a patient, and after touching the patient's surrounding. So this is what we should do for every patient and all the time. Whenever you're going to touch a patient, wash hands. When you finish touching a patient, wash hands. Before procedure, wash hands. After body fluid contact, wash hands. After touching the patient, wash hands. And after touching the patient's surrounding. And the picture on the extreme right is showing us the waste segregation. Please note that it is missing the brown bin, which is supposed to be for pharmaceutical waste. And then, of course, you can see that we are having the liners not matching the colors. But the most important thing is segregate the waste according to the level of infectivity or infectiousness. Substitution, this one I already said, you can have telemedicine, you can have screening at home, but even more importantly, you can have vaccination. Right now, we are having vaccination for Mpox, and we've also had successfully a vaccine for Sudan Ebola, which is actually the circulating type. Engineering controls, this is where now all of us should be looking at. You should have a screening area at the facility with the functional equipment. Make sure your temperature guns are actually working, standardized screening tools, have a holding area during outbreaks, enhancing hospital workflow, and then good ventilation and create access to hand hygiene facilities. Now, this might not be appropriately done for all situations, but at least make sure that you do the most you can. And one of those should include screening people in whichever way, and also having access to hand hygiene, and of course having a holding area, however small this can be. Then the administrative controls, including that includes changing the way people work, provide adequate training, and that is why this training is very good. Ensure appropriate patient to staff ratio, staff and cleaner schedules. This is again depending on the facility. Update and regular communication. And then develop a surveillance protocol for healthcare worker exposures and to all staff, and surveillance protocol even for the actual disease. For example, if it is Ebola, who is an Ebola suspect? Then ensure health workers and public recognize the importance of seeking medical care without delay. And of course, maintaining healthcare workers to ensure adherence to monitoring, to ensure adherence to standard precautions. So then we have the issue of putting on the appropriate PPE. This one, I don't even want to spend a lot of time on it because these are things you have seen, but we are going to have a practical demonstration. Then now we go into the issue of risk assessment. This is very key because when we are doing the PPE, you will find that there are situations where you see somebody who wants to have a full suit, others have maybe half a suit or just an apron and gumboots, and then people are wondering, what should I put on and where? So in risk assessment, we are saying who is at risk, and we've already seen that everyone is at risk, but are you at risk all the time? When you go to your home, are you still at risk, and should you still put on PPE in your home? So risk assessment in IPC is a systematic process. Please underline systematic, used to identify, evaluate and manage infection risks in healthcare facilities and community settings. So it helps to prevent and control the spread of infections by determining potential hazards and implementing appropriate mitigation measures. So this is why you select which PPE to give to who. If you're in a community and we are having COVID, then maybe the COVID-19 respirator is not what you need, but you need a normal mask. So how do we assess risk? We identify the hazard, then identify who is at risk, then evaluate the risk, and then decide on the control. If you're working in the bank and another person is working in acute care unit, are you at the same risk? No. If you're working in the intensive care unit and you're always intubating people, another person is working maybe in triage, are you at the same risk? So you keep reviewing and then decide on the control depending on the organism and the level of exposure. So first, how do we do it practically? Look for those things in your environment. That is the objects, the situations, the processes that have the potential to cause harm, especially to people. Then secondly, evaluate the severity and probability of the risk. That is why you see, for example, in HIV/AIDS, when you say, I have had live sex with, a suspected infected person, and then another person says, I have been very close to my friend and my friend has HIV. So you're looking at what are those things in the environment that are likely to cause harm. Then evaluate the severity and probability of the risk. Then you will know if I'm going to give PrEP, I will give it to the person who has had the live sex, whereas I will not give it to a person who has come in contact or has shared a cup. Then third, decide on the appropriate preventive or control measures. Is it PPE? Is it chlorine? If it is chlorine, what concentrations do you use? Then we shall finally go into the practical session for each of these, especially for the hand washing and for the personal protective equipment. Now, because of the time constraint, we may not be able to go through the mixing of the chlorine or the disinfectants, and we may also not do something on waste segregation, but they're not less important. But just because every one of you is a health worker and you're in this battle, this message is specifically to you, that our dear health care worker, you're relentless in your efforts in providing care, preventing diseases and responding to healthcare emergencies as you continue to save countless lives and strengthen the national health system. So we appreciate you and your efforts are not going to the drain. Thank you so much, and over to the moderator. Thank you.
Wonderful. Thank you so much, Dr. Ssuda. I think she's very elaborate. I think she's also very confident in her subject matter topic and very clear. And I think she has done justice in the time allocated to kind of break down the principles of IPC, the core components. And I know that during that point, we had audio issues. So in the Q&A, she will, kind of go over them again, because that is a very important aspect to understand. And then we talked about the precautions, standard and then the transmission precautions. And then we've had the hierarchy of controls, okay? How you go down to identify risk situations and address them, then risk assessment, and knowing who is more at risk than who and how do you intervene for a person who has been exposed to which kind of risk. And I thought that was flowing so well, as you can know. You can refer back to what you expected to learn and see whether you're achieving or not. And then ask questions. I think it is wonderful. It's best to type questions in the chat where Dr. Elizabeth, who is about to come on and introduce herself, but also clarify her role that she will be handling. Right about now, we are preparing to go into a practical demo for hand hygiene, and after that, donning and doffing, which are very, very important aspects or skills to know in this IPC training. So Dr. Elizabeth, before we go into the practical demo, Judith, I hope you're ready. Kindly unmute and, kind of introduce yourself to the attendees and also what you'll be doing so that they can be comfortable to register their questions in the chat. Judith, you're ready? Just a moment.
Right. Yes, please.
Yes, Dr. Elizabeth.
Yes, good afternoon, colleagues. My name is Elizabeth Katweigye. I work at the Ministry of Health, and I coordinate the National IPC Pillar of the Response. I'm glad to support the team with the questions in the chat, and I'll be sharing through other reference documents, including the standard operating procedures for Ebola for IPC with the coordinator, and this will also be shared out. Looking forward to the questions.
Dr. Elizabeth, are there any questions at the moment in the chat that can be registered?
I think most of the comments in the chat were around the presentations, which I guess will be shared. Someone had asked for more information about the core components, and I've shared out a reference. The other question is around the statistics of the outbreak, and we are waiting on the official report through.
Okay. Thank you so much. I note the issue of the core components. I think Dr. Ssuda has noted it, and we shall have a.
This information.
Yeah? She's breaking, yeah? Okay. Dr. Elizabeth, you're breaking, but we have noted that. And in case of any other questions in the chat, we shall be waiting. At the center here, I can't hear you very well. I hope that the data could be set for you. Right about now, we're preparing to be led by Sister Judith. Sister Judith is a nursing assistant officer at Mulago Hospital, as she introduced herself, and she's going to help us through the practical sessions of hand hygiene and then the aspects of I'll share. Okay. So, the background, help adjust the cameras so that people can appreciate what will be going on. But also we shall have the camera rolling. Judith, switch on, switch on. On.
Yeah, thanks so much to my colleagues. My name is Ouma Edwin. I usually tell people when it comes to donning and doffing, I know it's a very, very. So thanks so much, members. I'm sorry for that. Commander Judith, Assistant Nursing Officer in Mulago National Hospital. Members, when it comes to donning and doffing, I feel so happy and blessed because I'm talking to my fellow health workers. What you should put in mind that before you do anything as health worker, as you enter the hospital, think about yourself. That is your safety number one. After ensuring that you're safe and everything, then also think about the patients you are taking care of. Then also without forgetting the environment where you're working in from. So it's very, very important to be health workers. We know this is timely. But to me, I usually say that IPC, it should not be coming only whenever we have outbreaks. Let it be part and parcel of ourselves. So I'm going to invite my colleague. I want to demonstrate. These are things we've been doing. We are just going to remind ourselves what we have forgotten. And I've been telling other people, if you want to live longer on this earth, embrace IPC. It is the only way to go. This afternoon, we are going to take you through the steps of donning and doffing. I know most of us, we've donned and donned and donned, but nobody's an expert, members. That's why we keep on reminding ourselves how to don and doff. I think for the interest of time, I will be explaining as we go on. But what you should take in mind that whatever you're seeing here has got a reason or a purpose why we're putting it on. And whatever you're seeing in front here, they have different sizes. In such scenarios, we don't put on fittings, and we usually give opportunities to health workers to identify the PPEs by themselves so that they're able to fit in whatever they're going to don in. So, doctor, you're going to be my assistant. We are going to start donning, and of course, we are following the principles, and I usually tell people what gives me